Hi, I'm Dr. Tadi. I'm one of the stroke neurologists. Today I'm going to talk about acute stroke management, which is very important. Stroke causes, stroke is one of the number one morbidity that leaves patient with no speech, no walking, no talking. It has significant catastrophic effect. So any patient who is coming with acute stroke, we have to first usually the stroke patients present with high blood pressure and altered mental status. So don't try to drop the blood pressure down. The first thing, even before asking patient's name, is try to get that CT and CTA head and neck. As time is brain, every minute 2 million brain cells die and billions of synapses will die. So the number one thing to establish is last known normal. When was the patient is completely normal? That is the time when the stroke clock ticks in. Then after that we do CTA head and neck, and in the head CT you have to make sure there is no blood in the brain, and also the patient is not taking any blood thinners, and the blood pressure is less than 185, and glucose is normal. These are the big things I consider before giving TPA. There are so many inclusion and exclusion criteria, but most of the people try not to give TPA. So I think it's very, very important as the trend is moving now to, give TPA more and more to help the stroke patients. Thank you. Today I'm going to talk about acute stroke management. So time is brain. So the sooner we give the stroke treatments, the better the outcomes are. Now, especially giving TPA, the initial NINDS trial that was released in 1995, it showed the number needed to treat is 7 to 8 if you give TPA in first 3 hours. If you wait until 4.5 hours, the number needed to treat immediately goes up to 14. So it's always very important to give TPA sooner. Once you give TPA, based on the modern trials that came in 2015, Mr. Clean, Extend IA, Swift Prime, what it basically said is take the patient to thrombectomy if the patient came within first 6 hours and NH stroke scale greater than 6 and aspects is greater than 6. Today I'm going to talk about endovascular therapy for acute stroke management. Just by giving TPA, it only dissolves internal carotid artery occlusion only in 10% of patients, and middle cerebral artery occlusion in 20 to 30% of patients. So now after giving TPA, or in some patients they are not eligible for TPA. There are powerful treatments that are available now. Those are thrombectomy treatments. So any patient with NH stroke scale greater than 6 and last known normal less than 6 to 7 hours and aspects greater than 6 should be considered for thrombectomy without any further testing. But based on the Dawn trial and Diffuse 3 trials that came recently, the stroke window extended from 6 hours to 24 hours. So there is an additional criteria. Basically, you have to get an MRI brain after 6 hours, between 6 and 24 hours, where we do perfusion diffusion mismatch. We look for how much brain tissue is dead, how much brain tissue is living. If the dead tissue is very small and the living tissue is very big, then always consider doing thrombectomy. But absolutely no TPA after 4.5 hours based on the data available in 2018. So the number needed to treat in the dawn and diffuse 3, when they combine together, is almost like 2 to 3. So these are very, very powerful treatments. So any acute stroke patient, to recap, they come with high blood pressure and altered mental status usually. Some So always think about establishing last known normal. Get CT angiogram to establish whether the carotid is blocked or middle cerebral artery is blocked. Based on that, try to give TPA and thrombectomy in timely manner. If the patient is came between 6 to 24 hours, try to get an MRI brain or the perfusion scanning. We In recent days we use rapid software which generates the dead tissue and the penumbra, the living tissue. So thank you so much.